our afternoon block is dedicated to patient, families, and donor in knowledge translation. Before we get started, it is my pleasure to introduce my planning committee colleague, Sarah Douglas, who will moderate this afternoon's session. Sarah lives in Ottawa and works as a policy analyst for Health Canada. For the past 3 years, Sarah has been providing secretarial support to the Organ Donation and Transplantation Collaborative, working closely with the governance committees as well as the Patient Advocate Advisory Committee. So thank you, Sarah, for being here and accepting to moderate the next block. So enjoy your afternoon.
Thank you so much. Let's jump right to it. So for the next block, we'll have 3 presentations back to back, and then we'll have our open discussion and panel at the end after all the presentations are finished. So feel free to post your questions and comments in the chat throughout the presentations. And our first presenter is Davina Banner, Dr. Davina Banner, who will introduce us to patient-oriented knowledge mobilizations. So Dr. Davina Banner is an associate professor at the University of Northern British Columbia. She leads an interdisciplinary program of research that's focused on cardiovascular and rural health, along with research that advances the science and practice of integrated knowledge translation and patient-oriented research. Through her research, Davina seeks to improve the health of Canadians living with complex health conditions, along with studying methods and practices that support meaningful co-production and research. Marc Bains is the co-founder and vice president of HeartLife Foundation, a patient-driven charity whose mission is to transform the quality of life for people living with heart failure by engaging, educating, and empowering a global community to create lasting solutions and build healthier lives. Marc has been actively engaged in a wide range of health research, including co-leading studies exploring patient-oriented research methods and practices. So over to you.
Awesome. Sarah, thank you so much for that introduction. As Sarah mentioned, my name is Marc Bains. Happy to present along with Dr. Davina Banner, a friend and colleague of mine, on patient-oriented knowledge mobilization and really shifting the dial on knowledge creation and then translation. Before I begin, I would just like to quickly acknowledge that HeartLife and myself, I live and learn and work on the unceded and ancestral and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. Davina?
Yeah, and thanks, and lovely to see you all, and great to see some familiar names and faces too. We're so excited to be part of this event, and today we'll be focusing on patient-oriented knowledge mobilization, thinking broadly around knowledge translation across the whole research process, but also thinking more specifically about how that experiential knowledge, that lived experience, is so critical to the research process. And Marc, I know you're going to do our acknowledgements.
Yeah, no, of course. So, I mean, Davina and I aren't alone in this. Yes, we're the ones presenting, but we have a team behind us. I think there's 7 or 8 folks, on the core team. But then thinking about our participants as well, and our participants now, probably we're around 20 people or so that really came together to make this research happen. And then all of this wouldn't be possible without the Canadian Institute for Health Research, which is our major funder and a federal agency responsible for funding health and medical research in Canada. Next slide, please. The path to partnership was, I would say, a fun one, for Davina and I. We met about 6 years ago and have now worked on 5 or I think maybe almost 6 projects, and working on some really big ones now over time. What's really unique about it is bringing the research perspective, the academia side of things, together with the lived experience side of things. And we've contributed across multiple fronts, across multiple research projects, thinking about initiatives for HeartLife, thinking about co-leading research and activities, which 6 years ago was something that really wasn't happening with patients and caregivers. We've also gone together to Parliament in Victoria to talk about advocacy and heart failure together. And really at the heart of all this is the connection, the understanding of that lived experience, the understanding of the research and the impact that it can have, bringing those perspectives and wisdom in, and that when taken together can really help understand from a really foundational perspective what the challenges are, tackle the health issues, and then develop research that's going to ultimately lead to better health outcomes for people living with various diseases. So I mean, I'm very proud of this relationship, and I think really sets a standard as we move forward as collective groups to bring in that lived experience along with research. Pass it over to Davina.
Yeah, so knowledge mobilization is kind of becoming a more increasingly commonly seen term, and probably for most people, knowledge translation is the term that they've seen probably most commonly, but this is really an umbrella term, and it relates to really a wide range of different activities, everything from knowledge synthesis, where we bring together the results of many different forms of research, to dissemination, that is when we're sharing and communicating research findings, transfer and exchange of information, but most importantly, that co-creation or co-production between researchers and knowledge users, which includes people with lived experience. We know there are many different models and frameworks, and we see one here, the knowledge to action framework, and they each comprise many different activities, lots of, theoretical pieces, and it's very complex. But the process itself of mobilizing evidence, mobilizing knowledge, is really complex. It's so far from simple, it can feel like pushing a boulder uphill. We'll move on to the next one. And, why do we really care about knowledge translation and mobilization? Well, we have to think a little bit first about the translational continuum, or these death valleys. And so death valleys in research, and these are really kind of big gaps, if you like, occur when the research firstly fails to account for the realities of healthcare. And that means that the research in itself is not relevant or responsive. And this may happen, for instance, when we don't engage people with lived experience and those around them. The second death valley occurs further along the translational stage, and this occurs when the information is not created or translated quick enough into practice. That is where delays exist. Next slide. And these contribute to what we call no-do gaps, and that is, we know what we should be doing, but it's just not done. We've often heard that there's a 17-year gap between the creation of evidence and changes and effective changes in practice. I'm not sure if that's still the case today, but we still know that gaps exist. We also know that only around 60% of all healthcare interventions have an evidence base that's appropriate, and around 25% of interventions can be potentially harmful or even unnecessary. And this in itself can contribute to around $200 billion of waste in the health system. Next slide.
Thanks, Davina. I like that no-do gaps. I think I'm going to coin that one myself. I appreciate that term. But, it's, Davina mentioned around $200 billion in wasted funds, right? That's a lot of money that can make a good impact. And, yes, there's money involved and there's time involved, but, there's also people behind all of this research, and there's a human face behind it. During my introduction, you were told that I'm a person with lived experience with heart failure. Heart failure is an invisible disease. Probably if you saw me and I was introduced as Marc Bains, you wouldn't know that I lived with heart failure or had a heart transplant. And we don't see that. And the point being, there's people like me who we don't see that are impacted by this research and then the associated care that comes from it. And when the care is not adequate, when the research is not there, it's people really living with the diseases that suffer the most. And that's really the reason why it's so important to bring in that lived experience, to understand the challenges, to understand the gaps, to have those no-do gaps. We know the gaps, we know what we need to do. But hearing from that patient perspective to really develop the research and tackle the complex challenges that exist in healthcare. Next slide, please. And so we talk about integrated knowledge translation, and that's really the approach that supports teams to effectively and meaningfully collaborate. And that key word is meaningful, because we need meaningful engagement of the right research users at the right time and throughout the entirety of the process. It's not about bringing in a patient or caregiver at the end of your research project or after you determined what that research question is. It's a meaningful engagement throughout the entire process. So bringing in the lived experience, and not just patients, but their caregivers as well. So their caregivers and family members. But why really practice knowledge translation? Well, we do it because we do it because problems are quite complex when it comes to research and healthcare, as we all know. And really, we can get a better understanding when we bring multiple stakeholders from multiple parties together. When HeartLife started, it was in 2016, and it was the first time that really Canadians were taking a coordinated approach to heart failure care delivery. And we need to do the same thing with research, is to bring in these different perspectives, more specifically, including and engaging patients. And as I said at the beginning of this slide, is because they're affected by every decision that is made in research. Next slide, please.
So let's think about the what and how of integrated knowledge translation and how it relates to knowledge translation itself. Well, we tend to think of knowledge translation as just occurring really at the end of a project. We think about all those amazing different outputs, whether they're more traditional things like publications, but some of the more engaging and more targeted things like videos and so forth. But actually, knowledge translation is something that occurs across the whole process, and it's embedded in relationship. We know, for instance, in IKT, as Marc mentioned, that this is a collaborative approach to research, and it involves a partnership right from the very start, where ideas are conceptualized together, and right until the very end, where those findings are being shared, applied, and used. And it's for this reason we often call it research co-production, because it is a collaborative and shared process. And as I mentioned before, it's not really IKT if we don't have the right partners together. That is, the people that are able to impact change, but also the people that are able to give those real important lived experiences. And the how of IKT in itself is complex. It can take a long time to learn to get it right. And sometimes, despite all best efforts, it can be a bumpy road. But as Marc said, it's about meaningful partnership. It's also about sharing that decision making. And to do that, we have to kind of rebalance that power. We want to engage those with different experiences and different perspectives. And most of all, it's grounded in trust and reciprocal relationships. We're all in it together, and we all have a valuable position and role to play. Next slide, please. So patient-oriented research, I know all of you will be familiar with this, is considered really a new frontier. It's really become a very accepted way, an expected way too, of how we work together in research. It is a type of process, a lot like IKT. There's a lot of overlap where patients and those around them are engaged as partners in the process. But also the research focuses on those priorities and outcomes that are important to people with lived experience. It involves a wide range of stakeholders and partners. And we do it because we want that knowledge that is generated to improve the healthcare experience, our systems, and our practices. Next slide, please.
So I just want to tell you maybe a little bit about the study itself. We're looking at engagement in health research networks, specifically what organizational factors contribute to engagement-capable environments in health research networks. And so research networks like the CDTRP have important roles really in advancing healthcare through research. And a part of this, they also include the need, a major part of it, the need to include persons with lived experience, PWLEs, within the network as totality and the research throughout the process. And our work includes a systematic review, and as well as case studies, including in-depth interviews with people in organizations, focus groups with people involved in research studies, documentational analysis. I didn't take part in that, but lots of documentational analysis to understand what's out there, and priority setting workshops, looking at what really is important from an organizational as well as a personal lived experience perspective. And ultimately, this is all with the aim to develop indicators for engagement-capable health research environments. So really making sure that the environment is right for people with lived experience to be involved throughout the entire process, to be meaningfully involved, to have that impact, to create value along with the researchers and get the outcomes that we all hope for. Next slide, please.
And so we've been working away behind the scenes and looking at our analysis, and overwhelmingly across all of the networks, including our wonderful partner CDTRP, we heard from all stakeholders of the value and the importance and the critical position that people with lived experience play in research. And also we heard a lot about the many ways that people with lived experience contributed, whether that's through governance of networks, committees, directly in the research, and even helping shaping the way findings are translated and communicated with various audiences. Some early insights. What we heard a lot was that patient or that person with lived experience role is evolving. And I should qualify, we use patients largely because it's in a health related field, but we do recognize, and I just want to say that we know that is problematic, in that, you know, people with lived experience is probably the better term, but our funder, our federal funder, choose to go with patients, but that's a debate for another day. But but we did hear that role is evolving, and you know, we heard here, I don't think of myself as a patient, I think of myself as a team member. I've always been treated that way. We also heard that patients wanted to be involved in guiding priorities, and for many, they felt that they had been. I mean, you have your foundation right, your goals, your philosophy, but the number one thing I would say that makes this organisation unique or meaningful is that they have asked people with lived experience what their priorities are. Next slide. It wasn't all...
Go ahead, sorry, my apologies.
No worries. It wasn't all sunshine, and we did hear, you know, that there were gaps and there were challenges. We know this isn't an easy process and that we're all learning through this journey. Overwhelmingly, we heard, particularly from people with lived experience that took part in our research, that engagement must start earlier. And we hear here, I think that the research question generation isn't happening necessarily with patient engagement. So I think that would be a huge step towards where patient engagement is on a new level. And remembering, as we said, that knowledge translation is a journey right from the very start of how we even identify those issues. So there's still a need for us to go back and backtrack in that process. The need for equity, diversity, and inclusion was always also something that came up across lots of stakeholders, but in particular, people with lived experience wanted to advocate for better supports to engage people with diverse experiences and perspectives. And one participant told us, I feel it's a bit disappointing. I think for a lot of research networks, EDI or equity, diversity, inclusion is like a big thing, but like actually incorporating it, I've seen very little of this. So we know in terms of our knowledge translation journeys together, we still have a long way to go. Next slide, please.
And so what is, you know, when we talk about patient-oriented knowledge mobilization, just want to talk about some of the highlights and some of the things. And it's really to increase impact and the relevance of the research, I think, what we've been able to do working together. You know, research that really responds to the needs, values, and priorities of patients and the public, because ultimately that's the focus of research, is to improve what is happening with patients or people with experience, and then translate that to the public, reimagining what that health journey can be like. So not just the typical journey of someone in a disease state, but understanding the entirety of the journey and holistic approach and getting people involved, as well as then supporting advocacy for, with, and among patients. And I'm not, you know, Davina was right, you know, we had to use the word patients, and I'm not offended by it in this context, but we prefer to use people with lived experience, because that lived experience is what brings that value to all this research. And then ultimately fostering the innovation and knowledge mobilization. Next slide, please. So when we think about this, we think about humanizing it. And this goes back to, again, the slide earlier on, where we had the collective of people, is really humanizing research. So being able to humanize it, to put a face to it, to put a face in the name, bringing this patient experiences together, those perspectives and the stories, really bring that reality to the foreground. Having that accountability, really, you know, research can happen, but there needs to be accountability to ensure that it's happening for the right reasons, for the right people, and getting the results. And whether the results are good or bad, it's having that accountability to then share those results. Accessibility. Is this patients are asking for, as Davina said in some of those quotes earlier on, being involved earlier on in the process, having this information at their fingertips. It's that accessibility of data, that accessibility of information, inclusion, and then bringing that across a diverse group of people. EDI is so important. And safety of it all, right? Really highlighting the need for compassionate, human, and respectful and safe research environments. Something that's an open communication that really brings that voice in a comfortable way where you can contribute actively and not be afraid. I mean, I remember when I was first involved in research, I was afraid to speak up because I had all these researchers around me and I was just this lonely patient. But now I have that lived experience and I have to understand and sometimes even be told that there's that value there. So it's creating that safe atmosphere for people to be involved. Next slide, please. And so ultimately, what's next, right? We think about what's next in research and where people should go. And it's simple, patient-partnered research across the spectrum. Even research that's patient-driven. Think about the questions that the patients have that they want to solve for their health outcomes. And then patient-led. So having someone as a patient, as a leader, or co-lead, like we're doing with the new CIHR network grant for heart failure. I think big strides in that respect. Next slide.
Yeah, so the notion of keep shifting the dial is a message I say for all of us. Myself as a researcher, I know I need to continue to advocate for a change in culture amongst researchers and within research institutions. I have the ability to help disrupt those power systems, and I want to do it. I think for me, the opportunity to work directly with people with lived experience and to co-lead research in a very meaningful way is professionally and personally transformative. I don't want to do it any other way. And in fact, it just really changed my focus to being a researcher and to work as an act of service. And so, you know, I can bring methods, I can bring these different experiences, but seeing that we all bring different experiences and that there are new ways to do things. I think as well, and shifting the dial is continuing to advocate and support for the engagement of people with lived experience. These stories, these contributions, these leadership roles do change and they do make research more impactful. We know that, and the evidence is increasingly showing that. Research that is partnered with people with lived experience is more socially responsible, it's going to be more relevant, and it's the right way to do things. We have to continue to recognise the central role and wisdom that people with lived experience contribute, and as Marc noted, in a safe and responsible way. For me, it's recognising the gift of that experience, and it's a gift because it's given from people that have lived experience of often very complex health conditions, that live every day with various issues and challenges. It's not something we can ever take for granted. It is a gift and it is precious. Next slide. As we wrap up, I'd like to take the opportunity to thank you so much. We're always interested in connecting and discussing. We're passionate about this, you can probably tell. And we want to disrupt these spaces. So do feel free to reach out to myself or Marc. Our emails are here. I also want to put a quick shout out. As we noted, CDTRP is a fantastic partner in our research, and we're learning so much around patient-oriented research. We are still interested in learning from your experiences. So if you would like to participate in an interview or learn more about the study, please contact me or contact Shana. I know, shameless plug, but we would love to hear from you.
We would. And we would.
Yeah, and that concludes our presentation. Thank you so much.
Thank you.
Thank you, Davina and Marc. It's a really inspirational presentation. And yes, we can tell you're very passionate for the topic. And so thanks for sharing your learnings. And we look forward to hearing how things turn out, because I'm definitely interested in how I can apply it to my own work as well.